Coming up today, your worst day is their everyday. Hear what it takes to handle nursing at a level 1 trauma center, where you never know what the next injury is coming through the door. Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. Well, we hope you never need to visit the emergency department here at the University of Kansas Hospital. But if you or someone you love is having a stroke, a heart attack, or other emergency, a team of experts is working 24/7 ready to help out. Our ED at the 39th and Rainbow campus is also a level 1 trauma center, meaning specialists are standing by to try and save the life of the next person delivered by ambulance or by air ambulance. Today, we are meeting some of the ED and trauma nurses who balance adrenaline with compassion. Tiffany Clark is a nursing shift supervisor and RN. Nicole Duff works alongside her. So great to have both of you ladies here with us.
Thanks for having us.
Learning all about the ED today. We are also looking forward to talking with ED nurse Amani Dajani and surgical trauma ICU nurse Molly Yadav, who will show us around one of the newer trauma bays, which is a place that's basically designed to handle organized chaos. So we'll take a look inside there in a moment and get with you ladies here in a second. But Tiffany, as we know, our ED stays pretty busy. Can you give us an idea of how many patients that we treat in a typical day?
So we treat over 200 patients a day. So it can be an average from 230 to we've gotten as high as, I think our record is maybe 270.
So you see everything?
We see everything.
Anything?
Everything that comes through the door.
You never know what your day is going to look like.
You just never know, which is, the exciting part of emergency nursing. But, we have the very critical patient that comes in, but we have someone who we may not consider as high acuity, but we treat them as well.
So these days we know there's urgent cares on every corner, it seems like sometimes. And we also have an orthopedic walk-in clinic. Nicole, if you had a guess, what portion of patients could be treated at urgent care instead of coming to the emergency department?
It's hard to say because, like Tiffany said, we see so many people. Probably about 10% of the patients we see are of like a lower acuity. So there's potential maybe a few could go to urgent care, but our doors are always open, and whoever walks in, we're happy to treat them and make them feel better.
Well, trauma patients need emergency care, but not everyone arriving by ambulance is a trauma patient. So, Tiffany, what are some of the specific criteria that trigger a trauma activation before a patient arrives?
So obviously there's a traumatic mechanism involved, and then we can activate a patient based on type 1 criteria or type 2 trauma criteria. Our type 1 trauma criteria really has to do with vital signs of the patient, whether or not they're hemodynamically stable or unstable. And so our type 2 traumas is really focused on the actual mechanism. So it could be a gunshot wound, it could be stab wound, it could be a fall from a 30-foot fall. It could be a motorcycle accident, a bird scooter. It could be, lots of different things. People tripping on a curb. It just depends on.
So not the line of work for someone who likes predictability.
It is very unpredictable.
Right.
Correct.
Right.
Yes.
Well, when trauma team is activated, I guess we're kind of picturing like assembling the Avengers. Nicole, when the trauma is called, who is getting paged to all come together?
Yeah, so there's probably about 20 people or so that get paged to the trauma. In the ER, it's our ER attending, a resident, charge nurse, the stat nurse for the day, the ER tech, respiratory therapy, the SICU nurse, trauma attending, 2 surgery residents, the chaplain, blood bank, registration, anesthesia, lots of people.
Lots of people. A level 1 trauma bay is well equipped. It's highly organized and it's engineered for efficiency. And as you can imagine, it gets crowded in there when different specialties converge to save a life. Alexis Del Cid is inside one of those trauma bays this morning. Good morning, Alexis.
Good morning. This is a fascinating experience, and I'm glad to be here on a tour. You don't, as you said, Jess, don't want to be here as a patient. However, if you do find yourself here, you'll be very lucky to see these two ladies. I'm joined by Amani Dajani. She is an ED stat nurse, and beside her is Molly Yadav. Molly is a surgical ICU nurse who has special training as a trauma resource nurse. Amani, first off, it's very bright in here. It's very warm. Yeah. I kind of feel like the guy in Airplane. at that scene in Airplane where he's sweating buckets. Why is it so warm in here?
So it's so warm in here because there's a lot of research that's been done that kind of shows that the outcomes of these trauma patients is better when they're treated in a warm environment, kept warm with warm blankets, and given warm blood.
Which makes perfect sense. And then Molly, normally, as we were discussing at the top of the program, there's a whole crowd in here, more than just us three and photojournalist Alex. About how many people are in here with you during a trauma?
It depends on like the level of activation, but anywhere from like 10 to 15 people. And then you also have X-ray coming and going. So can really flux up to probably about like 17 people.
Which is a crowd.
Yes.
Which is a crowd,
Very
but
much
everyone
so.
has a specific job and also a specific place where they're stationed. So Amani and Molly are going to take me on kind of a tour around the bed. Let's start at the head of the bed. Amani, which doctors or nurses are stationed here?
So up here is going to be our ER team. So we've got our ER attending or supervising doctor and then the resident doctor. And their role is really to manage the airway. They're here to assess from essentially clavicles up, but their big role is to make sure that there's no need for an emergent airway or need for oxygenation of any sort, any form, whatever the patient needs.
And then at the foot of the bed is where you have
Your trauma attending.
Okay.
And so that's going to be kind of who's running the trauma. But there's really good collaboration between the two teams to ensure that the patient's best taken care of, essentially.
And then Molly and Amani, let's walk over here. Amani, where would you be stationed?
So I'd be stationed over there.
Okay, and then Molly, where are you?
I'm over in the corner, all the way over there.
Okay, over in the corner.
Yes. Behind the computer.
And what's your role?
So my role
Amani.
essentially is I'm kind of the T1 nurse is what you call it. And so my role is to make sure there's an IV or get an IV established, obtain blood if needed, or trauma will obtain that, and then kind of just ensuring that the patient's getting medications. This is like essentially my patient along with everyone else's, but I take primary on it while they're in the trauma bay.
And Molly, you're the TRN, Trauma Resource Nurse. What are you doing throughout this whole process?
During the trauma, I am basically being the documenter. So the ED charge nurse also helps document, and they'll throw in orders for us under providers' names. But we document from like the second we get the trauma page until we get them to their final destination, taking vitals every like 3 to 5 minutes, documenting everything that the doctors and nurses that are working at the bedside are doing on the patient.
And while we continue with this tour, I'd love for Alex to show you all at home what it looks like in here, the wide sweeping view with these huge lights and all this state-of-the-art equipment, and it's so organized. We're going to get to the organization in a little bit. Molly, how long is a patient typically here?
It really depends on the severity of the trauma case, but anywhere from like 10 minutes to 45 minutes, depending on like how long it takes to stabilize the patient before we move them on to the CT scanner.
And when you're moving them on, do they always go to a CT scanner or sometimes straight to the OR?
About 90% of the time they go to the CT scanner, but if there's a very obvious injury or
Right.
something that we see on what we call a FAST exam, which is an ultrasound of their abdomen, then sometimes they can go straight to the operating room.
When they're traveling en route to the next step, what's your role?
I'm pushing at the head of the bed, monitoring the patient, documenting vital signs, administering medications. I basically take over as the primary nurse once we leave the
From
trauma
start to
bay,
finish.
and a lot of times the trauma nurse will come along if the patient's unstable as well.
When it comes to then getting ready for the next patient, because as we said, it could be go, go, go. How long does it take you, Amani, to restock, reorganize, and clean up each room before the next patient comes in?
So, I mean, the second that patient leaves, we are resetting everything. You kind of take note of the things that are being used every trauma that you're in, so you can very promptly restock them. Our techs help a lot with that. Our housekeeping's great. They come in, reset everything, and then we're ready to go.
So in addition to saving lives, you're mentally categorizing each supply that's been used and how much of it has been used. Do you feel like you're in here so often? Could you find supplies at the drop of a hat?
Probably. It definitely
own?
takes time, and that's kind of part of our training to be the stat nurse. But yeah, essentially anything that you need, I could grab you.
Amani was saying when we were talking before this program that if we blindfolded her, I said, could you find things? And she said, yeah, probably. You could just find it by muscle memory.
Yeah.
Probably. This is fascinating. Is there ever a time when there's more than one patient between trauma bays and both of you ladies are going from room to room to room?
Yes, I mean, typically what happens is like the charge nurse, the ER charge nurse would be in one of them, Molly would be in one of them,
Okay.
I'd be in one of them, and then there'd be basically the entire team that we have here reset in each room.
But you two would stay in the same room with the same patient from start to finish. That is, it's so fascinating. And also this, if you like being organized, if you're watching at home, just looking at how neat and clean and everything is set up, it's an organizer's dream in here. I would feel very safe being in here knowing that I had everything state of the art and people taking care of me with anything that was necessary. Jess, this is a really cool experience. How bright are those? I just got to ask you about the lights. Does it get even brighter in here when you turn those on?
Even brighter.
Like the sun? Is it like you're in the sun? This is wild and so clean. Back to you in the studio, Jess.
That's perfect for you, Alexis. Anyone who doesn't know you, they would know that you're like in heaven right now. It's
Right.
clean, it's perfect,
Well-
and it's perfectly organized.
You'd want me organizing. You would not want me in charge of saving your life.
Exactly. That is true.
I could
Very
make you
true.
laugh, but I can't, yeah.
That is very true. Thank you, all three of you, for that very cool behind-the-scenes look this morning. Tiffany, those trauma bays, they were part of the recent ED renovation. Compare them to the old bays.
So we're very, very fortunate that we were able to get that renovation. Before, we had a trauma bay that was large enough to accommodate 2 patients, and so it was one big room, 2 trauma beds with a curtain in between. And so we still had everything we needed to be efficient and to be able to care for the patient, but these new stat bays, we have 3 of them, we're very, very fortunate. They're very, like the team said, very high tech. We have all the equipment that we need, all the supplies that we need. They're very, very efficient. So they're set up for speed to jump in and do some life-saving measures right away.
Yeah,
So,
makes
yeah,
doing your job.
super nice.
Yeah, for sure. Well, be sure to ask your questions. You can drop those in the chat on YouTube or Facebook, or you can email the Medical News Network. That information is right there on your screen. Well, we asked our emergency medicine doctor, Brian Beaver, and trauma medical director, surgeon Stephanie Berry, to kind of imagine what it would be like running a trauma without nurses.
Running a trauma without nurses would be completely impossible. They are vital members of the team. They help with the assessment, they help with making sure we have IV access, they help with calming patients down. You can imagine it would be an incredibly scary thing to be in the trauma bay or after a car wreck or fall or any of those things.
I think our emergency medicine, our trauma nurses have a unique skill set. Number one, they have to be able to stay really cool under pressure. We have really sick patients that need things done right away. There's a lot going on. They've got to be able to stay cool under pressure. And our nurses here are phenomenal at that. And then they've also got to be able to manage multiple patients sometimes at the same time.
We all descend upon this room, the team that's assigned to that for the day. And we have to trust each other and know that each person that comes to that situation is trained, competent, and ready to go, because there's not really good on-the-job training in the trauma bay. We need to be prepared.
We heard Dr. Berry mention trust. Not every nurse is automatically trusted to work on a trauma case. So Nicole, what do you have to prove in order to earn that trust and become STAT certified?
Yeah, so our process to be STAT certified is pretty lengthy, so I think that helps build that initial trust. So to be STAT certified, you have to be a nurse in the ER for 1 year, and then you have to take the trauma nurse certification course. After that, you can take our trauma workshop that our educator teaches, and then you'll do a 6-hour shadow shift of a STAT nurse for the day. And then after that, you can do the 2-hour checkoff in the STAT bay, where you're given various scenarios, and you have to be able to anticipate what you need, be able to locate where it's at, and set up the equipment that would be needed. So that very lengthy process helps build that trust. And then we also have once a month like a trauma simulation, STAT committee meeting, a trauma committee meeting, and a trauma video review.
So what does it mean to be STAT certified? What are you now able to do?
You're able to go into the STAT bay and take care of the trauma patient. So if you weren't STAT certified, you wouldn't be able to go in the STAT bay and take care of that trauma patient.
Can't even go inside there.
Nope.
Molly, you are a surgical trauma ICU nurse and a trauma resource nurse. How does an ICU nurse become then a trauma resource nurse?
So like the ED stat nurses, we take the trauma nurse certification course, and then we get trained by our educator on the trauma narrator, which is the way that we document anything that happens in the trauma bay. And we also, it's something that probably takes like about a year and a half, or 2 years once you're a surgical ICU nurse, for your team around you to have the confidence and trust in you to build that trust. And you also need to be a resource to the unit as well. So it's a specialized role, but a lot of our nurses get to do it.
Tiffany, what happens behind the scenes to improve communication among the trauma nurse members?
So Nicole mentioned a few of the things, but one of the biggest things that we've done recently, the last couple of years, we have started having a trauma simulation practice. And so that's been really great. It's really focused on communication and collaboration. What we realized is we all have really great skills. We're really good at our jobs individually, but what we needed to work on was the communication and collaboration amongst all the different teams that respond. And so this simulation practice is just about collaboration and communication. We also have trauma video review, which we review all of our type 1 traumas. It's a really great opportunity for everyone to come together. It's non-punitive. It's just for us to learn about each other, about what we can do better next time, improving care for that trauma patient. And then, of course, Nicole had mentioned the several committee meetings that we have. Again, it's everyone on the trauma team can come together and talk about improvements and how we can just improve what we do.
And you said that everyone has a voice during a trauma case, but how does that work when everything is so chaotic? Does it just seem like a regular day for you? It seems chaotic to the rest of us. How do you manage that?
It does seem like just a regular day for us, but we've had lots of practice, and so lots of mental rehearsing, and so we've learned how to stay calm in these serious situations. When we say everyone has a voice, so we really practice the one clear voice, meaning one person at a time is talking, but that doesn't mean only one person can talk the entire trauma. So everybody has a voice to speak up for the care of that patient, and so we have to rely on each other to be able to use very strong closed loop communication, again, as part of that collaboration. And so it's very important that our emergency department techs have a voice so they can speak up when they see things that need to be talked about. The nurses can speak up. Our respiratory therapist, our trauma lead, our emergency department doctors, everyone has an opportunity to speak up if they see something, or if we need to change the course, or if we notice a patient decompensating. So when everyone's focused on their very specified skill, it's very important that you trust the others around you to be able to speak up when they see something so that things can be adjusted if needed.
Makes sense. Well, we hear helicopters landing pretty often around here. What changes when a patient arrives via air ambulance versus a regular air ambulance?
Just the way that they get into the department, really. Nothing changes in the trauma bay necessarily. It just means that we have to have, we usually will have a stat nurse and stat tech go up and meet the flight team upstairs on the helipad, and they come down by elevator, and so we're just there to help escort them, and into the trauma stat bays they go.
Earlier in your career, did the idea of a trauma patient rolling in, you had just saw her that first time, did that make you anxious? Nicole, I'll start with you. I want to ask all the nurses.
I'd say, yeah, the first time, definitely a little anxious. You get all the training, you've seen it being done, but that first experience doing it yourself is a little nerve-wracking. But then after it's over, you're like, okay, my training prepared me for this. I got this.
You got this. I like that. Tiffany.
Same thing. It's very intimidating when you first go into a trauma for the first time. Obviously, lots of training. You're prepared so well for it, but nothing prepares you for that initial anxious feeling that you get. It's like butterflies, your heart's beating, and you really have to calm yourself.
I bet. I bet. Amani, Molly, I want to ask you, what is it like? Was it the idea of treating a trauma patient for the first time, did that make you anxious?
Yeah.
Yeah, for sure.
It's kind of like, you kind of get little butterflies and stuff, and it's a little overwhelming initially, but there's good support, and once you do it quite a few times, you start to feel a lot better.
100%. I totally agree.
Amani, Molly, I want to ask you, these are, of course, life and death situations. You have to speak directly, no nonsense. How do you find time or even remember to be compassionate in these types of settings?
I think it's just remembering that there's a person that's having their worst day in the middle of the room, in the middle of all the chaos. And so remembering even the small things like introducing yourself and telling them who you are, what you're going to be doing, like kind of leveling with them, being real, like, hey, I know this is overwhelming and stressful and you're probably in pain and you're scared, but we're here with you. I think always remembering that it could be your loved one or even you in the bed, because a trauma can happen to anyone.
Yeah, 100%. Just seeing them as a person and not just another patient. Advocating for your patient and talking with them, telling them what you're doing, and it's very, very overwhelming for them, and clearly their worst day, like you said, but the things that we can do to make them as comfortable as possible.
Nicole, Tiffany, yeah, things are moving really, really fast. How do you find that time to be compassionate in those moments?
It's the same. You have to realize that that is a human being laying there, and you have to not only focus on the skill at hand, like what you're trying to do to care for that patient, but you have to take that opportunity to let them know, we're here for you. This is what's going on. We're going to take care of you. We're going to do everything we can to get you better.
Yeah, it's just like any other patient that comes in, always introduce yourself. I'm Nicole, I'll be your nurse today. I'm going to get an IV on your arm. There's a lot happening, but we're going to take great care of you.
I want to talk about workplace violence. It's an unfortunate reality for nurses everywhere in any department. But what do you do when a patient needs treatment, but is also aggressive or possibly threatening you? I want to ask all the nurses, and Tiffany, I want to start with you.
So workplace violence, it's a reality, unfortunately, and it's not just unique to our health system, it's unique across the country. It's something that is increasing across the country. And so it is challenging because, we're nurses and we want to care for the patient, and we want to do everything we possibly can to take care of that patient. And when a patient were to become combative or verbally abusive, physically abusive, it can absolutely hinder their care. And so that's difficult for us, but we also have to keep ourselves safe, because if we're not safe, we can't care for the patient. And so, again, I don't think it's unique to this health system, but the way our health system handles it, I feel like we're very supported. It is something that is not acceptable, especially in the emergency department. We do train our staff in de-escalation techniques. We let our staff know that it is not the expectation that you are to be mistreated and abused. So we have a lot of systems in place. We have a PD department, our own PD officers. We have protocols in place that will help us respond to patients that are becoming violent. And we do our best to avoid it at all costs. It does happen sometimes, and then when it does happen, there's a lot of support for that nurse or any staff member in the emergency department that comes in and really helps support them and get them through it.
Nicole, any comments on that about workplace violence?
So I agree with a lot of what Tiffany said. We get training on how to de-escalate and recognizing those early signs of someone that may escalate, and ideally intervening early before you get to that point of full-on like aggression or threatening. And then having the police in our department as well, just kind of that extra support for us as nurses is comforting.
Molly, Amani, can you add to our conversation about workplace violence, how you handle it, or if you've ever encountered something like that?
Yeah, for sure. I know the emergency department probably sees it a little bit more than we see it in the surgical ICU, just because of the volume of patients they care for on a daily basis compared to the volume of patients that we care for. But one of the most important things is having a great team around you who's always there to back you up and help you in a situation if you're feeling like it's getting, if it's escalating, and also the amazing training that we receive here in de-escalation techniques really helps.
Yeah, I can't echo that enough. We've got great training and great support, and it's definitely become, unfortunately, a norm in healthcare, but also become a norm that isn't acceptable. It's talked about a lot more, and really managing those situations has been brought to the forefront to encourage staff to speak up.
Well, we want to get to some questions from our viewers this morning, and I'll stay there in the bay with you ladies. Molly, can you answer this one? What is the gear hanging from the ceiling in the trauma bay? And what are some of those other machines in there, and what are they used for?
This is our Philips monitor. It's how we monitor heart rate, blood pressure, oxygen saturation, respirations, all of the things. We have a manual blood pressure cuff because your first blood pressure that you get in the trauma bay is manually done by one of the amazing stat nurses. We've got some oxygen over here, suction. There is a lot. We also have surgical lights in case they need to do any sort of small operation and need some more light. There's a ton of stuff in here, but yes, that's the main stuff that's hanging from the ceiling.
Gene has a question. He wants to know what do the nurses do between traumas? Nicole?
We're usually taking care of other patients in the ER. So the stat nurse does, their main role is to respond to those traumas. So when there's not a trauma, they are helping out all the other nurses with their zones. So taking care of other patients, going out to triage, helping triage patients. So we're always busy. Someone's always doing something.
Jeremy wants to know if you have any rituals or routines when you get home to try to turn off that high stress and that adrenaline at the end of a day in the trauma bay.
Yes, so it's interesting for an emergency department nurses. It's just, trauma, sick patients, and you're just caring for them and you're just amped up the entire shift. And so I find it very helpful when I get into my car to just have complete silence. It gives me some time to be able to arrive at home and then be available to my family, because you have to be able to turn your emotions back on. Not that we don't have emotions in the emergency department, but we have to kind of hide them a little bit because we have to be ready for the next patient, whether this patient was, unfortunately didn't make it, or was not very cooperative, or, there's just a lot of situations we have to deal with. And so, it's trying to become normal again when you get back home. So sometimes just some silence in the car as you're driving home, just to kind of de-escalate and make yourself calm again.
Any rituals for you?
I try to leave work at work. So taking deep breaths, listening to music on my drive home. And then the minute I walk through the door and I see my husband, I just try to let it all go. And my therapy at home is, working out, those things that fill your bucket back up.
Amani, what's your way of decompressing from a stressful day?
I'm more of a morning person, so I like to wake up early. I like to work out before work, kind of decompress before I even go to work, and then kind of like Nicole and Tiffany said, leaving it at work, and then when I get home, I'm just present, there for my dog, my fiance, so.
Molly, what about you? How do you bring that adrenaline rush down?
Well, I work night shift, so by the time I get home, I am ready to go to sleep. So I jump in the shower and then I'll read a book or watch a show or something and go to sleep and just forget about it until I wake up in the afternoon, and that's when I do my workout. So that helps too.
I love it. Everyone has their own routine, so that's great. Molly, I'll stay with you as we wrap up today. What's the big takeaway? What do you want people to really grab onto from this conversation?
Just to know that they're in great hands when they come into our trauma base, even if it's the worst day of their life. They have the best team around them to care for them, and we're highly trained and organized, and we're ready for whatever walks through the door.
Amani?
Yeah, I just want everyone to know that, they're in great hands here. We've got plenty of training, and we all really want to take care of them, even though typically it's not their best day. We're going to make it as good as we can for them and try to help mend whatever it is that's broken.
Well, thank you for your hard work and all that you do for our patients. And thanks for the show and tell today, ladies. Appreciate you. Nicole, what's the big takeaway?
As you heard, the ER is a very busy place. Our doors are always open, and it takes a lot of people to care for just one patient. So just knowing that we're doing everything we can to get everyone seen as quickly as possible. We've got extensive training, so we're well prepared to take care of whatever comes through that door.
Tiffany, wrap us up today.
we're not just adrenaline junkies there in the emergency department. We care about you no matter what whatever your injury is when you come into the department. So whether it's super critical or not critical, we care about you as a human being, and we're going to do the best that we can to get you seen.
I think you have displayed that very well here today. So thank you so much for sharing your stories with us. We appreciate you, all of our guests, and we appreciate all of our viewers for being with us today. Have a great weekend, and we'll see you back here on Monday. Coming up Monday on the Morning Medical Update. Growing up, Mallory Contreras was never allowed behind the wheel. So what's changed? I'm Jessica Lovell on the next Morning Medical Update. The years-long journey to understand her epilepsy, plus the implant keeping her seizures in control. Monday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now everywhere podcasts are available.